We have seen some difficult macular hole surgery. So when it fails, management of failed macular hole surgery is my topic. So before defining failure, let's look at success. Success is when we have a type 1 closure, where is the continuity after the closure. If you have a continuity of the ellipsoid zone of the photoreceptor, that is type 1 closure. Either in type 2 closure, you can have either a V type or a U type closure. In both cases, there is a discontinuity of the ellipsoid zone of the photoreceptors on SDOCT. So there is another type of closure. You see, this is not a failed macular hole. Here there is an outer lamellar defect. This is not a fail. These kind of cases takes longer time for the reorganization of the outer retinal layers. So this is not a failed. So now what is failed macular hole surgery? It is assumed that in all these cases there has been an adequate ILM peeling and there is an adequate gas tamponade of at least 1 to 2 weeks, a good tamponade and prone positioning. So usually the ones which fail are the large ones with more than 800 microns size, or chronic holes with subretinal precipitates or RP degeneration, large myopic macular holes with foveal schisis like this, or large traumatic macular holes. So the usual surgical techniques that we use for prophylaxis of this miserable condition, it is better advised that these cases undergo large, the high risk holes undergo inverted flap technique. And the simplest of the surgical procedure is repeat fluid gas exchange in an early failure. When the hole fails within short period like 2 weeks of surgery, you have to think that either an inadequate positioning or inadequate tamponade has happened. And the other two procedures which are being used and which we will be discussing with videos are free ILM flap technique and lens capsular flap transplantation. The rarely described techniques for a failed macular hole is arcuate retinotomies, radial incisions, autologous free retinal flap from the temporal periphery, and so on. So the inverted flap technique, first described by Navraki. So he said we peel this ILM in a radial fashion towards the macular hole, bring it till the edge of the hole, from all the sides, bring it till the edge of the hole, and then trim these flaps and fold it into the macular hole area. So how it helps is because these ILM flaps have neurotrophic factors which helps in the migration, rather than only scaffolding. It helps in the migration of Mueller cells, which again secretes neurotrophic factors, and that helps in the reorganization and survival of the photoreceptor cells, causing a macular hole. So now once all these flaps are trimmed, it is fluid air exchange is done, and generally with a soft tip cannula, the flap which is trimmed is placed into the whole area. So this is basically done to prevent a failed macular hole surgery when you have a large hole like 800 micron. So the simplest surgery available for a failed surgery in the early period, that is like 2 weeks from the surgery, you see that hole you have a small bubble up and you see the hole is still open. And if you have this kind of a configuration where you have elevated edges with a cuff of retina with subretinal fluid rather than a flat punched out hole, you have a high chance of closure with just a repeat fluid gas exchange with a long-acting gas tamponade like C3F8, because here the causes of failure is different. It's just inadequate positioning or inadequate duration of tamponade. So when these are few cases wherein you can see these cuff of retina standing up with a little bit of subretinal fluid, which closes with just a simple fluid gas exchange. So the commonest performed procedure now for failed macular hole is ILM free flap, wherein a small piece of the ILM is taken from the edge of the already peeled area and put it into the macular hole. So various people have tried different techniques of doing this. However, we feel that rather taking from the edge of the already peeled area and putting wherein the flap can float away. So better done under PFCL. Under the PFCL, you can inject BBG dye, and that stains this ileum. The edge of the ileum area can be seen quite clearly, and then according to the hole size, just pick up a small flap of ileum from the already nicely seen area like this and shift it under the PFCL. Just place it on the macular hole. As you can see, now that flap is lifted and put it on the macular hole. So, and just use a soft tip or instrument to slightly nudge it into the macular hole area. And after this, a careful fluid air exchange at the disc with low air pressure has to be done so that this doesn't get dislodged during the FAE procedure. So even people have tried, because of the dislodgement of the flap, people have tried attached ileum transplantation, wherein the ileum, a hinged flap is raised, and the tip of this flap is put into the tucked into the macular hole area. As you can see, under the air, you can see the flap tip is under the macular hole and this helps in closure of the macular hole. Another technique that we do, and it is being advocated now, is a lens capsule transplantation. For example, in a pseudophakic patient like this, the posterior capsule is just dyed, use dye, trypan blue or ICG dye to stain the posterior capsule, and with the microforceps, take pick a small piece of the posterior PC, posterior capsule, which is dye is applied, and put it on the macular hole, and gradually with the forceps nudge it into the manipulate it into the macular hole area. If not tucked properly also, it stays there, and careful fluid air exchange is done so that this doesn't get dislodged. So post-operatively, if you look at it, these flaps are seen up to 2 weeks or 1 month following the surgery until the macular hole closes. So this main mechanism, how this helps is by acting as a scaffold, preventing the fluid from entering into the macular hole, and also helps in the migration and of the Mueller cells. And as you can see here, 1 month later, the hole has closed, and the scaffold of the tiny remnants of the capsular flap is also seen. So even if it's a case which you do a combined cataract surgery along with failed macular hole surgery, you can do a cataract. Trypan blue stained anterior capsule is preserved during the cataract surgery. It is kept moist during the cataract surgery, and after that it is hand fashioned into a 1 to 2 millimeter size according to the size of the macular hole. And then after a fluid air exchange, this capsular flap is with a drop of visco applied on it, can be just placed on the macular hole. So this again acts as a scaffold over this macular hole and results in closure of the macular hole. This is how it is being placed on the macula with a drop of viscoelastic, which helps to retain this capsule in position. So this failed surgery with this capsule as a scaffold, it closed after in the post-operative period. So the other techniques described, like autologous retinal free flap from the temporal periphery under the perfluorocarbon liquid. After the cautery, a small piece of retina from the periphery is removed, and under the PFCL, it is taken and placed over the macular hole. So it was basically done for failed myopic macular holes, and you can see the flap in the initial period. Later phases, it is taken up, and you can the retinal flap is taken up, and you can see the closed macular hole. Steve Charles described arcuate C-shaped temporal retinotomy, which is temporal to the macula, and this fashion of creation, this doesn't cut the nerve fiber layer, because that is according to the configuration of the nerve fiber layer, and gradually, slowly, the retinal bridge here is nudged nasally so that there is a horizontal shortening of the macular hole, and it closes. That is the mechanism. This is one of the patient of failed macular hole following temporal arcuate retinotomy. So the radial incisions also have been described for large failed traumatic macular holes, wherein sparing the papillomacular bundle, one disc diameter radial relaxing incisions have been made, followed by fluid air exchange and long-acting gas tamponade. So the adjuvants that are used for all these procedures, which we flap surgeries and transplant surgeries, are mainly viscoelastics, autologous platelet concentrate, or whole blood. So this is mainly used so that after the ILM flap or retinal flap or the posterior capsular, posterior capsule of the lens is being placed there, these adjuvants are used so that it doesn't get dislocated from the area of macular hole during the fluid air exchange and the postoperative period. So to conclude, the above described techniques are useful, especially for large and refractory macular holes which have failed the standard procedure of ILM peeling and gas tamponade. These novel techniques are advancement in surgical techniques with better anatomical outcomes, but the long-term functional outcomes are yet to be analyzed. Thank you, and I thank Dr. Karan and Dr. Saravanan for the help in this presentation. Thank you.